And let me just first start by saying big appreciation to Mr. Malloy and Mr. Mason for helping us out on this training and obviously on the development of this, as we'll get into. So, um, kind of the overview for the session is Andy will give kind of some background and history into their research and why they kind of stumbled upon and felt the need to develop some better solutions for particularly the posterior ankle. And then Lyndon will get into a bit more specificity around some of the approaches, some of the morphology, and some of the implant design. And then I'll go through a bit of the specifics around what is in the kit. And then we will do a little bit of comparison against some of the competitors we've got on the market. So that's the overview. For just the sake of sanity, I guess I would ask, a lot of you are already muted, which is great. But since we've got so many people on here, if you're not talking, go ahead and mute yourself so there's less background noise. That'd be great. And then after each kind of section, we'll take some, maybe do a brief Q&A before we transition off to whoever's presenting. If that sounds all right. All right. Andy, I'll go ahead and make you presenter.
Cool. Well, thanks very much, Dustin and Elliot. And I'd just like to say how excited I am. It's been quite a long journey with this. Working with Ortho Solutions has been fantastic. It's obviously been difficult with COVID and everything. Things have been a little bit delayed, but I think the future is very exciting for this. And I think the reason behind it is how much evidence the product that you're going to be selling is based on, which I think is going to be absolutely key for getting excellent market share. So what we're going to do is just go through how the journey started and how we progressed up to where we are now. So for those of you who don't know me, I'm Andy Malloy. I work with Lyndon in Liverpool University Hospitals over in the UK. So it all started with an audit. So I, in 2012, felt like I was coming across quite a few failed ankle fracture fixations and having to deal with a lot of complications. So we decided to go back and look at the last year. And this is what we found. So 94 ankle fractures were fixed, 33 were mal-reduced, and there was a major complication rate of 8.5%. So I collected all these cases and then got them independently reviewed by a surgeon from Switzerland and one from the States who came up with this figure. So we presented this both nationally and internationally at AFS, and it was really nice at AFS, as a few people said they thought it was the best paper there because it was so honest and showing what it was like, is that people weren't taking the necessary care or not appreciating how complex they were. So we presented the results in the department and went through a period of re-education, which was a slightly stormy few meetings, as you can say, because people don't like being shown bad results some of the time. But we went through that period of re-education and we left it another year and we went back and had a look. And this is what we found. It got worse. So 43.8% complication rate and 10.9% major complication rate. It was only from reading afterwards, and I'm quite interested in reading in psychology and things, is that realized actually it was a mistake in what we did in in just trying to use education alone. Education alone is very poor at changing behaviour. In fact, Cialdini I think he won a Nobel Prize for his work on the normalisation of poor behaviour. So what we needed to do was a system change. So we changed our whole process of how we dealt with these fractures. Now, one of the criticisms that was put to us is that it's just your hospital's rubbish, you're terrible. And there have been 3 other presentations at BOFAS and at least 3 others that I know of at local audit meetings that found the same. Some surgeons in the States did the same in the bigger institutions where trauma was shared out amongst people, and they found very similar results. So the system changes that we went on is based on really a mnemonic by David Halpin came up, who's in the Department of Behavioral Change, which is based on the same unit in the US, which was set up by Barack Obama. And to produce change, it needs to be easy, attractive, social, and timely. So what we did is we said any surgeon can take on any fracture they want, but if you don't, all you need to do is give the name to one of the nurses and they'll contact us and we'll do everything else. We have dedicated foot and ankle trauma lists. And I think a really important thing was the quality control is all trauma, and we now do this with elective, is all cases are viewed by a body of attendings the day after. For trauma is weekly with the elective. And then from this, we started to try and develop different ways of trying to treat them to improve them. Now, the reason why that was necessary, I'll come back to in a minute. So after we went through this system change, is we found that more of the complex fractures went to the foot and ankle surgeons than they did before. So what was the changes with these system changes? Well, you can see here. So with the system change, you're having people who are interested doing it. The right surgeon for the right fracture is we went from 44% malreduced to 2.4%. Those fractures that were malreduced were understandable because of their huge complexity. And the major complication rate went down massively. So we combined the data with Leicester, another one of the major hospitals in the UK, and went to see what the effects of these were. So what we looked at was how well reduced they are. Now there's a pretty poor scoring system or grading system, which is from the JBJS back in the 80s, called Petroni's. And basically for each part which isn't properly reduced is you get a point. So you can see as you get increasing amounts of malreduction, the OMAS patient reported score decreases significantly. When you go to each specific fracture type, is that obviously you can see the OMAS score is worse if it's malreduced, such as this top one compared to the other one. But there is a standout group of fractures here. So even if they're well reduced, the B3 fractures, i.e. the posterior malleolar fractures, scored distinctly worse than even your true pilon fractures. And if you didn't reduce them properly, they had absolutely horrific scores. So this pushed us along. How can we treat these differently? What can we do to improve this? Because it's what we were doing, what everyone was doing, wasn't acceptable, because to only get an OMAS of 59 in someone who is quite often young and fit is poor. So the age-old question, does size matter? I'm happy to report to this learned audience that size doesn't matter. There was a paper in FAI in 2011 where the American surgeons, 97% would fix 50%, but only 10% would fix 9%, and in between as well. But traditionally, what everyone was taught is if it's less than a third, don't fix it. And that was the same in the US and the UK and around the world. And certainly for my board exams, that was the standard answer. A rhetorical question, does anyone know where that figure comes from? Well, it comes from a well-known orthopedic journal, the Journal of Surgery, Gynecology and Obstetrics, where they looked at 8 cases. Apologies that I can't see the date of the paper. It's just that I can't get the view thing off the screen. And so basically, there is no evidence for this. It's just something that's been perpetuated by being repeatedly quoted in papers. The other one which supports it was actually an orthopedic journal, but it was back in 1959. And again, no patient-reported outcome measures, obviously, very small numbers. But they even showed, even at sort of 10%, that there was subluxation, and that's really all they were looking for. The other thing is, what is a third? So we do this in trauma meetings from looking at the radiographs. So how big's that? Well, that's a small fragment off the back. This one, actually, you start to see you going to a much larger chunk. This one looks like a big chunk, but the rest of the ankle looks okay. Actually, you can see it extends all the way across and is really sizable fragments. This one, well, with an eye of faith, you can see something there, really. You can see the fibula fracture. It's not that severe a fracture. And look, you've got almost circumferential loss of all ligamentous structures. So how reliable is that plain radiograph? Well, there's a plethora of papers looking at this and showing that it is completely unreliable. So CT changed surgical management in all studies. The posteromedial fractures can't be visualized on plain radiographs, and it's just really guesstimating. So we changed to CTing any fracture which looked complex, and certainly if there was even the smallest fleck off the back. And the reason I wanted to do this is see if we were comparing the same type of fractures, which meant that we could go up to developing a classification system. So the one which is historically used, and I'm really pleased to say that ours has got real traction in the literature now, is the Haraguchi one. But this, although it's descriptive and they're about the same types, it's not in ascending order of severity, and it's not or ascending severity of injury or type of injury. So we looked at 121 consecutive treated posterior malleolar fractures to look at these in detail. So what we found is that there's type 1, type 2, which is split into 2, and type 3. So type 1 is a PITFL, so posterior inferior tibiofibular ligament avulsion. Type 2 is a rotational pilon, and type 3 was an axial loaded pilon. So the type 1s. So here you can see that the foot is inverted, and as it does, it pulls on PITFL, which pulls off part of its footprint. Now, with these fractures, what we found is that they were mostly low fibular fractures, but with all of them, there was an injury to the syndesmosis. So in a quarter of them, it was just the posterior syndesmosis, and for 3/4, they had a full syndesmosis diastasis. But also, there was a high incidence of deltoid injury and of quite a small anterior collicular fractures, which we'll come on to later when we're looking at the competition for plating options. Are very difficult to get with some of the things that are out there. So how do you tell whether there's a posterior syndesmosis injury? Well, you do an internal rotation test as opposed to doing the external rotation test, which people do for the anterior part of the syndesmosis. So here's just where the fibula fixed, and as we internally rotate, you can see between the two that the gap in the syndesmosis has widened. Here we put the screw in, and obviously that doesn't it doesn't move at this stage. So for your type 2, this is a rotational pilon. So you're getting external rotation, And as it externally rotates out, the talus hits the fibula, which knocks out the posterior part of the tibia, and as it goes further, it extends across. So this is why you get a type 2A, which is just this one fragment, and 2B, which is the secondary fragment there. So what we found is these happen in a very predictable pattern. Really, no matter what the size of the patient was, as there was very little difference in the range of these, of where the type 2A fragment was on this right ankle, again, the type 2B fractures on another right ankle. So with these, you're starting to get a higher fibular fracture. Diastasis occurs in, there's no diastasis in half of them, but again, you're getting a lot more variability in the medial malleolar fracture. So with the syndesmosis fracture is that if you fix the posterior malleolus, is most of the syndesmotic stability comes back, whereas it doesn't if you just use a syndesmotic screw. But also the accuracy of that reduction of the syndesmosis is far better if you fix the posterior malleolus. So here you can see where if you're using the syndesmosis, you put a screw across. If you place the clamp poorly, what can happen is it can start spitting out the back, even up to extremes. And this is something which does happen, and this was in a paper in FAI in 2019, where you can see that spat out the back and the screw is actually through the posterior malleolus fracture. So when it comes to the type 3, this is an axial loaded pilon, so the foot's in full plantar flexion, there's axial force, and that knocks off the back of the tibia, as you can see on the schematic here. So these tend to be far bigger chunks than, if you like, the true posterior pilon. So with these, there's a far lower chance of diastasis, again, getting higher and higher on the fibula, and it's more Y fractures and posterior oblique. So with when we look at these, is that for the different types, it's PITFL, rotational pilon, and axial loaded pilon. So again, type 1, type 2A, type 2B, and type 3. So what was the treatment algorithm that we came through for this? So one is a syndesmotic fixation, because it's just this small avulsion off the back, and it's too small to fix. 2A, you need to fix, and because it's just a lateral fragment, you go posterolateral. 2B, there's a variation in approaches that you use, and Lyndon will go over that in a minute, and type 3 would tend to use a posteromedial. So after we came up with the classification and how you'd approach these are the OMAS scores that we got. So you're looking at sort of between 70 and 76 at 1 year. So I'd just like you to compare that to what we originally showed in ones that were fixed, and fixed well, the ankles, but obviously not the posterior malleolus. So beforehand it was 54, now it is 74, which is statistically significant. And this was published in the JBJS Open Access. And I was delighted to say for the American Board recertification exams, they choose 30-foot and I think it's 30-foot and ankle papers to read. And this has become one of the papers that is part of their required learning. So since then, it isn't just our study. There's been 8 of the papers, level 2 to 4, showing functional results equivalent to a bimalleolar ankle fracture with fragment-specific fixation. And this treatment algorithm is highly successful, and the products that you guys have to sell will aid in that reduction and enable more surgeons to do this well. So, in summary, the historical treatment of posterior fracture, posterior malleolar fractures resulted in poor outcomes. The size doesn't matter, and any posterior malleolar fracture needs addressing, and that's dependent on our algorithm. You need to get a CT because you just can't judge how big that fragment is from the radiographs. And if our algorithm is followed, then there is a statistically significant improvement in patient clinical outcome.
All right. Thanks, Andy. I really appreciate that. I think it's good for everybody to get a little bit of background, certainly in terms of how things started. Let me transfer over presenter to Lyndon.
Can I just ask a couple of quick questions?
Yeah, please.
Just very quickly. So is CT now standard practice for this across the UK?
I would say that it is definitely getting there. I think there is still resistance. And if I'm being honest, even sometimes in our unit, before we merged, if it was a day when we weren't there, you'd hear about grumbling saying, oh God, it's just a tiny fragment that it doesn't need to be dealt with. And how I explain that to some of my other colleagues is that if you say they have an ACL, you can get an avulsion called a Segon fracture. It's the equivalent of that. It's not the size of the fragments, it's what that represents. So I would say with the amount of evidence out there is that you would legally start getting into difficulty if you have missed something and you haven't CT'd it.
Right, okay.
There's now 11 papers proving that you have to CT it.
Right.
If you is very on discussion with the guys in major trauma centres around the UK, it's normal practice now. The smaller DGHs, as with everything, they're slow to catch on or slow to evolve in them situations. But I agree with Andy, from a medical legal perspective now, if you don't CT these, and it proves to be a lot bigger fragment than you expect, there's no defence really for that.
But the thing we must add is that you can't decide how you're going to treat it if you don't CT it. So it's not just defensive medicine about the medical legal consequences. You don't know which arm of the treatment algorithm that you should go down. So if you look at some of the historical papers like Anish Kadakia's in 2009, where started talking about fixing all of these, is they fixed every one of them through a posterolateral incision. Lyndon will go through this about why you can't just approach them all in the same way.
Right, okay. And just the second question was more of an observation, really. So, when you started the presentation in 2014, you looked at 94 fractures that were fixed, and then in 2017 there was 205. Why was there such an increase?
So it's twofold. I mean, to be honest with you, that's an amalgamation of a few different lectures. The unit got busier as it headed towards being a trauma centre, and there were differing periods of time that we looked at the patients over. As to be honest, in my own naivety, after the period of re-education, we only did a relatively short review because we thought, oh, it would have got better. And when you saw that it got worse is when it really sort of kicked you into action.
Yeah. Thanks. Thank you.
That's another point on that one, though. So from the initial audit to the last audit, Liverpool became a major trauma centre. So it went from being a small district general hospital and treating ankle fractures that just come off, sort of skateboards and such, to people who jumping out of buildings. And yet our results and malreduction rates got better. So even though the complexity of the work got much, much worse, we got much, much better.
Are there any questions from anyone else at all, or do you want to take questions at the end, Dustin? Or?
No, if people have questions now, giddy up.
Seriously, I mean, it's an informal session, so please feel free to pick up brains at any point. It's
Okay, happy for me to go?
Yeah, I think go ahead. Giddy up, Lyndon.
Okay, so there's a little bit of crossover from Andy's talk. I can't really do without a bit of crossover because a lot of it circles back to what what Andy's just been saying. But so this is a commonly used learning curve that you can see on the internet, really. And I must say, it was very much like this when I started doing these postural-malleolar fractures. I'm sure Andy would agree with me, where everything, the more you knew, the less you knew, the more you found out. And I'll explain that now in a bit more detail. So the first one I want to say about is the peak around the fibula. And this was on Twitter, I see this all the time. So the American surgeons are very, some American surgeons put a lot of their cases on Twitter. And the peaking around the fibula is a very obvious way of fixing the postural-malleolar fracture, because you keep them in the same position. You just tilt the leg and just try to sneak around the fibula to get it. Now, there's a number of problems with that. Number one is that when you do so, you tend to malreduce the fracture. And the second part is actually where the perineal artery is. So if you sneak around the fibula, you essentially are at risk of damaging the perineal artery trying to approach it. So when people start doing postural-malleolar fractures, this is the first way that they start doing it, because they're doing it in a way of comfort. And we did this. Well, I did it. And this is the typical example. And you got this very typical lateral plate with a fixation from the back. And you can see the actual postural-malleolar fragment is here. And the reason for that is because it's been fixed too lateral, because it's been malreduced with that rotation. The next easy way to do it is actually fixing the fragment from the front to the back, because they put them in the supine position, fix a medial and lateral, and then you just put some screws on the back. Now, there's a number of problems with that. Again, you're trying to fix a wall to a picture rather than a picture to a wall. It obviously doesn't make much sense. But also there's some problems with it. This is an example that came up from another center for revision. And you can see as they fixed it from front to back, not only has it got an intercalated fragment, it's also hit it and pushed it off. Yeah. Also, you can get soft tissue entrapment. This is a case where there was some tibialis posterior is actually wedged in the fracture plane. So if you try to fix this and try to get compression, what happens is actually you get tib post problem. And there's quite a few actually level 1, 2, and 4 studies showing a significant improvement in both anatomical reduction and functional outcomes with a direct approach. So it makes sense to go from the back. That's the first thing. Okay, so we're going from the back now. So the common way to do it, as Andy alluded to, the initial papers was doing a posterolateral approach. And for the BOFAS, this is currently the way they teach it, doing the posterolateral approach. It's a study that we did publish last year, but it's based on work that we'd done earlier. It's just a publication came out last year on the different fragment. And if you're going to put a line down where the best screw or best fixation you get, where would that come out? We found with this that 74% of cases that we had in this series required a posterolateral incision. But you had all these other ones, like the type 3s, which were posteromedial, or type 2Bs, where you had to do these combined approaches, is that you needed other approaches. So just doing a straightforward posterolateral incision did not encompass 100%. And this is just to show you that graphical representation. So you can see the type 2As and type 2Bs. When you got this posteromedial fragment, you can see that this is where you need to get to it from. And same with the type 3, actually straight down the middle is much better, much easier to approach. Also, if you measure the size of the fragment, so this is another paper we produced last year, you measure the size of the fragments, you can see the medial posteromedial surface area is much larger compared to the, so these are the surface area of the different approaches. And you can see the medial posteromedial, you can get to majority of the fracture. And also, this is the extensile because it's along the fascial, the medial fasciotomy line. So you can extend it all the way up to tibia. And if you compare this to the size of the fractures itself, You can see the type 3, which is much larger than what you can get to with a posterolateral incision. And this is in the paper that we produced. You can see the posteromedial approach. You can see you can get straight through the middle here. So very good for the type 3s. The medial posteromedial approach, you can get to these type 2B medial fragments. But for the type 2As, you can get both the fibula and these lateral fragments. So we got basic principles here, which is we're dealing with 3 different fractures. The fragment-specific fixation from the back is clearly the best. And we need options of 3 incisions to best approach and best fix them. And so obviously, Andy's already talked about a classification system. These are 3 different fracture patterns. But what I'd like to allude to is the rotational pilon, because this is taking a long time to get into the psyche of orthopedic surgeons, that as they rotate, because the posterior aspect of the tibia overhangs the talus, like does the medial malleolus, as it rotates, it hits it and pushes it off. And this was the liberal algorithm. I know Andy's already said about it, and I'm going to go through each approach as we do this. So first of all, the type 1s. So these are the little fragments you can see off the back, and these just require syndesmotic fixation in our algorithm. So whatever your poison is, this one's obviously had a screw fixation. This one's had a tightrope. I do tightrope the majority of these myself. Your type 2A, so your rotational pilon minor. So this is the smaller, just the 1 fragment rotational pilon. So this is an example here. You can see this fracture fragment. This one is much easier to approach in the prone position because you need to go from the back rather than sneaking around the fibula. I do most of them in this recovery position prone now rather than the true prone, just because it's the knee just prefers it. But you can also get to the medial side a lot easier. So to go through the posterolateral incision. So this is the initial, oh, I'm missing a slide. Okay. It's actually, you draw a line between your fibula and the lateral aspect of your fibula from 7 centimeters from the transmalleolar line is where the sural nerve, which is this one here, starts transversing to 7 millimeters below the fibula. And this is what you need to know this because you need to protect it as you're coming through. The next, and I talk about it when I teach in 3 pops, but I just find it easier when you're teaching. And the first pop is your investing fascia. So that's the fascia that surrounds all the structures of the lower limb. This is the investing fascia here, you can see. And as we're coming through this layer, that's the first layer. And what it takes you down to is the next one, which is the layers, the fascia over the top of both the flexor lucis longus and your peroneal tendons. Now, what's important to note is that there's a blood vessel between these. I know some surgeons were essentially going through one and then going into the other through the sheath. That's a bad idea because your peroneal artery is there, and because there's a perforated peroneal artery going from posterior to anterior, it's not very mobile. So as you can see, I'm into both sheaths rather than go from one to the other, and then we can pull move the peroneal muscles medial or lateral, usually lateral when you get the fibula, and the FHL the other way. Open up the sheath, and there we have the posterior aspect of the tibia. And this is where your 2A plate fits, as you can see here. Obviously, this is not the plate. This is from because the plates are not being used as yet. It's a different type of plate. So this is from the Striker set, a little foot plate. Because these fragments are pretty small. You don't need a big chunky plate. This is another one again. You can see subtly posterior subluxed, fibular fracture. This is the fragment. It's the 2A type. Same approach, but also if you're going to get the fibula through the same approach, we just move the peroneal muscles medially, and this allows you access to the back of the fibula. Well, I'll talk about this when we go to the competition, but actually having a jig that attaches to the plates and having K-wire holes is really useful when fixing the back of the fibula. And this is the kind of result we're going to get. this is the case. You can see this ankle is now sitting perfectly flush. The type 2B rotational peel on major. This is when it keeps on rotating. You can see the fibula has come out of its incisura. You've got this fragment and then a fragment that sits under the posterior lateral fragment. And this is very important as it sits underneath. We'll talk about that now. So the medial posterior medial approach gives you access now to this other chunk. This chunk, this type of fracture pattern, I would expect to do a postural lateral and a medial postural medial. So this one's pretty easy, as you can extend it, as I said earlier, along the fasciotomy line, and we're trying to come into this tibialis posterior area. So again, the first pop is your investing fascia. Your second pop, tib post. Then move tib post towards the tendon Achilles. That protects your neurovascular bundle, which is the other side of it. And then you can take off your periosteum, which is your third pop, to give you exposure to this fragment. And because this fragment actually spits out medially, the plate sits in this position because it's trying to push not only in the posterior to the anterior direction, but also to the medial to lateral direction. And the reason for that is this. What we found is that when we actually started fixing these, if you fixed it and squeezed this lateral fragment, what happened, it closed this space down and this medial fragment spat out. So you always need to fix the medial side first, and this is on our algorithm. So this is an example of this. You can see a type 2B. It sits underneath what this fragment, obviously it's very displaced at this point. And when it's been sat down, you can see this fragment here. This is your medial fragment, because this has been spat out. This has been inappropriately spat out when the posterolateral has been fixed first. So this is another one. You can see the double shadow on this pre-op. And as we fix this back, this one's been fixed first. You've still got the posterolateral fragment, which is sitting off. And again, this is on a plate, a non-specific plate, unlike the ones that we now got. As we brought that down and then brought the posterolateral down, we then have got a reconstruction of the ankle. This is a much larger one, where it actually extends into a tibial fracture. And this one, to give another example, is that where the plate is actually sitting with the posterior medial fragment, as well as getting fixation from posterolateral. And then the type 3 are your true posterior pelons. So these are the big chunks, up to 6 centimeters we found on. So these are the largest ones we see. These ones are much easier to approach the posterior medial, because you hit it dead on. And to get the posterior medial, we're looking to come next to the tendon Achilles and then tuck underneath the tendon Achilles and then hit the FHL straight on. So this is your initial approach through the right next to the tendon Achilles. That's your first pop. And then you come into the FHL knowing that your neurovascular bundle is just here. So that's why we have to tuck underneath the tendon Achilles. We don't want to go anywhere near here. We want to come this side of the FHL. You bring FHL medial, therefore protecting your neurovascular bundle. You open up your periosteum, and then this gives you access to this fragment. And this is your type 3 plate. So type 3 plate, because this is a large chunk, the T plate is what we've designed for this. So this is an example of such a fragment. And I fixed it with, at that time, a buttress plate, but also a screw from back to front to get compression. This is another example, again, type 3 fragment. And again, being fixed in a similar manner to get a reconstruction of your ankle. So the next thing is, what about the syndesmosis? So back in about 2015, 2016, there's quite a few papers came out. Miller was the one that's most cited about the syndesmosis. Now, as we said with the initial paper in 2017 that Andy showed earlier, as we go up the classification, the chance of getting a syndesmotic injury actually decreases. So not all of them have syndesmotic injuries. All your type 1s do, half your type 2s, and about 20% of your type 3s. This is from that paper. You can see the number is 100% for your type 1s. So the question was well, why? Why are some having, even the small chunks, having more of an injury to the ligamentous structures when the bigger chunks are not? And the reason for that is due to the very large superficial component of your PITFL. And this is the paper that we done back in 2019 showing this. And if you compare this to the size of the fractures, actually, the PITFL is generally bigger than any fracture pattern. So your ligamentous injury has to occur with a fracture. There's 5 papers indicating, however, that it does reduce your chance of requiring a syndesmotic injury if you do fix the back. It doesn't completely negate it, though. So for some of the type 2As, for example, you fix the back, and for a lot of them, that's fine. You don't need to fix any more of the syndesmosis. But if the front is gone as well, you need to fix the syndesmosis as well. And it doesn't matter the size of the fragment. So it's all business of, well, the bigger fragments we have to fix and the small ones we don't is now null and void. And I put a few papers, hopefully Dustin will share some of the papers I put for further education on that. Long term, there's only one current paper, medium to long term, the level 2 study, follow up 6.3 years, not one of ours, but they showed that the articular step off was the biggest indicator. So if you don't reconstruct the articular surface, you have much worse functional outcomes and much greater chance of arthritis. And that's where I'll end.
Okay, thanks, Lyndon. Any questions at this point for Lyndon?
Yeah, I had a question on the approach there. So if you've got a 2B and you're doing a posterior, medial incision, and as you said, sometimes you come again with a posterior lateral. Do you, what considerations are like
the
patient?
MPM,
Yeah.
the posterolateral and medial posteromedial are usually combined for the type 2Bs.
Right.
So if you don't do a direct postural, posteromedial can sometimes get you to both fragments.
Okay. Are there any particular, like if you've got a diabetic patient or someone older, you know, how does your patient selection go into that? Do you consider, is the wound healing ever an issue when you have those 2 incisions and that small separation?
The width between them is very large. It's about 7 centimeters in the average patient. Also, your neurovascular bundle goes between them. If you're going to have any problems with wounds, the posterolateral is the one. The reason for that is because the perineal artery supplies some of that area. So if you're going to have wound problems, your direct lateral, which most people fix an ankle through, and your posterolateral is where you're going to have wound problems. Your medial posteromedial and your posteromedial generally don't have wound problems.
Yeah, I mean,
Thanks.
it's not something that we've come across as being an issue. It's not something that we've come across as being an issue in having wound problems with this. I know when we discussed it when we first started with the surgeon design team, is that one of the guys in particular was saying, "Oh, people, you're going to have problems with it," but it's just not something that we found. If you leave them for the swelling to go down, and actually it makes more sense because when people have said, "Oh, right, just use the posterolateral incision," is you're going to need to extend that quite a distance up, and you're really going to have to tug on everything to try and get across to get your screw going at an orthogonal angle to the fracture thing. So actually, you're doing less dissection. As you said, people would think because there's less subcutaneous tissue that the medial one would be the problem, but actually it's really it's got a really good blood supply. It's the posterolateral. If you don't take care of that perineal perforating artery, I think that you would run into more problems with that.
So there was also a paper, not from our center, looking at the 2 incision approach. I think there was 89 in the series came out this year. Showing no wound problems. Because of this is not a direct medial incision, it's a posteromedial incision. The area, number one, has a lot of soft tissue over the top of it, and number two, it's your blood supply is very close. It's actually got a very good blood supply.
Just a quick question, please. So you mentioned BOFAS, Mr. Mason and Malloy. Are they mandating the UK NHS and specialist foot and ankle surgeons to fix these sorts of fractures now, or is there no mandate or diktat around that? Just given the obvious complexity that I think people underestimated previously, perhaps.
So there's no, you can't really mandate this type of thing anyway. But what we have found with BOFAS is that this has now become normality along BOFAS itself. It's not BOFAS that is not fixing them from the back. It is other surgeons who fix ankles. So people who are not foot and ankle trained, who are in other specialties and just doing trauma, general trauma. But it's foot and ankle itself is this is normality now for us.
Yeah, so BOFAS runs various courses just as AOFAS does, and for the sort of fellows and residents courses, that is part of it's one of the sort of standard lectures about posterior malleolar fractures now. In the UK, historically, we have been some issues, particularly from the trauma centre in Edinburgh, that they were saying that you can ignore them and just use the fibular nail. I mean, we can get into a full discussion about that, but the papers, that's gone off now, has it, for the fibular nail results?
No, we've got it. It's been done. It just haven't been written yet. We presented in BOFAS, got second prize in BOFAS with it. I think that with to add that to the Edinburgh group. So they've now invited me to the Edinburgh. So Tim White has invited me to give a lecture in the Edinburgh Symposium on posterior malleolar fractures. So even the Edinburgh group are starting to sway.
So just broadly speaking, do we know what percentage of these are finding their way to foot and ankle surgeons versus just general traumatologists? Just keen to know that.
This is one of the sort of, I think that the single important things is that there are some traumatologists who they do is trauma, and they will be really good at ankle fractures as well. It doesn't just have to be a foot and ankle surgeon. It's just that the right person, whatever their overall speciality is. We've got a couple of knee surgeons who are really good at these. They're just providing that they get fixed in the correct way. You start getting into difficulties if you start telling people, right, only you've got to be a fellowship trained foot and ankle surgeon to do a posterior malleolar fracture. Is that people really don't like that. So the approach that we've tried to take in our unit is anyone who is happy to do them would be delighted to, because actually we've got too much work to fit on the foot and ankle trauma lists.
Thank you.
I've got a quick question, Jesse, over here in the United States. I apologize. I could probably dig into the paper and find this out. But what was the percentage of tri-mal fractures of all of your ankle fractures?
So that's a great question. So if you have a look in the literature, so tri-mals is about 20 to 30% of the general ankle fractures. Ankle fractures that require fixation, so ankle fractures that are unstable and require fixation. However, and we were discussing this the other day in clinic, is that virtually all of ours are now tri-mals. We don't know why. We don't know whether or not it is because we look for them, or whether or not it's because we have a poor social economic area and therefore have a higher propensity to young patients having osteopenia or bigger injuries. But our numbers are much, much higher in regards to people who have tri-mals.
So, I mean, I'll come on to this when I go on to talk about the competition for the Acumed system, but one of the papers that theirs is based on was one of the other papers by Anish Kadakia, and they looked at just over 250 fractures, and they found that 50% of them had a posterior malleolar fracture. However, they only scanned a very small percentage, so that will have underreported the amount of posterior malleolar fractures.
Yes, thank you. Yeah, I'm curious, with a lot of surgeons here only using X-ray and not CTing, how many maybe missed in the States?
Yeah, so I think that's one of the things is I think when you're turning up to people say, "Oh, I just don't see many of them," and I think then it's really, I think the sort of the pack of papers and the references and things that hopefully we're going to put together will be absolutely crucial in saying that it's something which is underreported, and the significance of it is really severe, really, that if you don't pick these up, you're going to have people who do badly, and you can't do that from X-ray. So it's a thing of suspicion. You wouldn't get in any of the trauma meetings if there was a pilon fracture or a tibial plateau fracture that people wouldn't CT it.
Right. Thank you.
Any other questions at this point? All right. So we're going to move on to getting into now the actually specifics around what we call the Volution plating system. So as far as the surgeon team, which was alluded to previously, but in the sake of thoroughness, we have we're really trying to make sure every design project now we have, we're being inclusive as far as an MD from US, a DPM, and then a designer as well from the UK region. So we're on each and every project moving forward. That's going to try to be our MO, and for the most part, we adhere to that. So Dave Thorderson down in LA, Sam Adams down in Duke, Sean Grambart is our lone DPM here. He was a past president of ACFAS, which is the organization for podiatrists here in the States, and then an MD down in Houston. And this project was actually brought to us by Lyndon and Andy, thankfully. So a lot of this work, as you can tell, has been going on quite a long time in their mind, and then obviously in their publications as well. Just touching on a few bits of relevant patents. We filed 4 design patents for the different plate families within what we'll be showing you. They're all pending at this point. None of them have issued. We also have a pending patent on what we call or term the V-lock technology, and that's just the interface between plate and screw, which we'll also get into here momentarily. So from a high level, just want to point out, some features and benefits, I guess, as we're starting to get out and about to talk and sell the system. So just generally speaking, before we get into the specific ankle fracture plates, there's some advantages to the Volution plates in general. One of which is, as you can tell, is a dark matte gray. That finish is a type 2 anodize, right? And so that's different than a type 3 anodize, which is a color anodize. When we do a type 2 anodize, it's also called a hard anodize, and it increases the fatigue strength by 25 to 30% right off the bat. So that's certainly advantageous from a fatigue construct standpoint down the road. Additionally, it also provides increased lubricity and anti-galling properties. So sometimes previously you may have had cases that you've been in where there's some cold fusion or cold welding going on between the screw and the plate. If they're trying to explant something, there's the propensity for that happening is a lot less likely to happen with the type 2. Further, we have no differences in metals, right? So we're not using any harder metal on the screw versus the plate to try to to cut into the plate for the locking mechanism. We're not putting a tin coating or a nitride coating on the screw head like some people do, Wright Medical and Paragon specifically on some of their systems in order to try to get intentional cross-threading or plastic deformation occurring. What we do, again, using our V-Lock technology, should afford us minimal cross-threading. So all that to kind of say, cross-threading in a perfect situation is not ideal. It can create debris in the wound site and overall less construct strength down the road. So V-Lock technology, and again, this is patent pending for us, and I think is a real differentiator, albeit not every surgeon will appreciate it. But this allows us to throw screws in off axis at a variable angle with not having to cross thread. Now, we've tested this up to a 30-degree cone, and you're free to allow the docs to do that. I think as you approach 15 degrees off axis, you are more inclined to cross thread. But if you're only a few degrees off axis, there shouldn't be any cross threading occurring. And the rationale for that is if you look down at the image on the right, the main difference is that if you look at the angle on the thread on the plate versus the angle on the thread angle on the screw thread angle is about 60 degrees, which is standard, versus the thread angle that we put on the plate is 30, which is not typical at all. It's generally 60 on both. And so what that allows is 15 degrees of play, both kind of above and below the thread angle on the plate. And so I appreciate the fact that, this is a two-dimensional image. And so we live in a three-dimensional world. And so that, as I mentioned, if you do throw this screw in just a couple degrees off axis, it's very unlikely that it's cross-threading. But if you throw it in at 15 degrees off axis, you probably will get some cross-threading going on. Having said that, we have designed, most of these plates we designed are anatomic in nature, and more than likely, we are not going to throw screws that are 15 or more degrees off axis. So specifically getting into some of the ankle fracture stuff, and I, this is basically a synopsis or elevator pitch of some of the items that both Andy and Lyndon have discussed. But I think what Ortho Solutions has designed and what we're now commercializing is the only evidence-based ankle fracture solution out there commercially available. When I say that, what I mean is it's based on the pathomechanical fracture classification that both Lyndon and Andy have talked about, where they've used 121, I think it was, consecutive CT scans. That publication is in Foot and Ankle International 2017. That initial publication was basically a blueprint that led to their algorithm, right? So that you've heard him talk about try to mandate CTs. You've heard him talk about where the incisions should be. You've also heard Lyndon talk about the approaches, all of these things, and even some of the manner in which fragment should be reduced first. So all of these things have led to an entire algorithm, right? And so we have used essentially the same data as far as the CTs go, as well as 80 healthy CTs to come up with our plate design, right? And so our plates are designed around their fracture classification, the size of their fragments, and that has also helped us ideally optimize the screw locations within each of those plates. So they've also talked about, and I probably need to change this to 20-point increase in the OMAS score, as they've reported in the JBJS 2019. We've mentioned the fracture classification, and that is alluded to here in the different colors on the bones here in this CAD model. This is an image taken right off of the front page of our brochure that were created. But ideally, or I guess theoretically, this is, and I think we're going to get into this a little bit more here when we start comparing versus some of the competition. I think the biggest differentiator is the anatomic plates and the fractures that they address from a posterior standpoint. I think everybody has a medial plate and a lateral plate. I think there's some nuances in ours that are still differentiated. But I think the single biggest differentiator is the posterior component to it. So just digging in specifically and having a look at what we are offering in our kit, these are the tibial fracture plates. So on the left are the type 3. In the middle, then, we've got the left and rights. Medial mal is the MM. And then for the fracture type 2A, 2B, we literally call them those plates, right? So they sync up in nomenclature as well with the M&N fracture classification scheme. The medial mal plate, I believe Lyndon made mention of this, and probably will later down the road as well, is obviously for a vertical shear fracture of the medial mal, but it also has capability of addressing the anterior collicular fracture fragment as well. And these plates, I can't emphasize this enough, are very unique in nature and are not analogous to like the hand plates or whatever that are currently being used back there by a lot of folks. The anatomic fibular plates are shown here. They come in 4 sizes. The small, medium, and large have exactly the same footprint distally with the distal cluster there. The extra small is worth noting that it's slightly differentiated from the other 3 in the sense that there's only a cluster of 3 instead of 4. But other than that, they're identical. We didn't go any longer with the anatomic plates, and the rationale behind that was if the fracture is further up the tibia, then it's not likely, the fibula, then it's not likely to be super distal, and you would just use a longer tubular plate, which I'll show momentarily. I think the biggest differentiators here that we have on the fibular plate are the amount of incorporation of fibular twist, which is not evident at all in this picture, but it is in some of the others I've got. As well as what's completely unique is 2 K-wire holes that are that allow for fixation to tack down the AITFL for the Wagstaff fragment, which is also depicted later. Here are the tubular plates, which would typically be used, obviously a lateral fib, but this is also going to be our posterior fib. So if they're doing a posterior approach, a lot of times the fibula would also be fixated posteriorly. As far as the specific plate dimensions, obviously, not the intent here is not to memorize, the overall length, but I do think it's worth noting the thickness is. So overall, these are very low profile, probably a little bit lower profile, certainly than like the Synthes and some of the other, purebred kind of trauma plates that are out there. We go down to 1.3 millimeters distally, both on these tibial plates as well as the anatomic fibula plates. And then as they traverse proximally, they get a bit thicker. So the tibial plates go up to 1.6 millimeters thick. The tubular plates are a constant 1.5 millimeters thick, and the anatomic fit plates are 1.3, and they slowly increase the thickness up to the 1.8 approximately, as shown here. The other thing to note is that there are K-wire holes in all these plates. K-wire holes are 1.75 mil in diameter. We also have a slot here, which is 1.75 diameter. The slot obviously is not for a screw. It's just for a K-wire fixation to aid in. That could be the first potential K-wire or olive wire that you would throw down so that you could optimize plate placement. You can also utilize placement of a wire through that in conjunction with the CDD, compression distraction device, if you've got a stubborn fracture that needs to be displaced to open up and clean out. Other than that, I think it's worth noting that olive wires, we do have olive wires in the set. They can be utilized in any or all of these holes as well, as the tip of the olive wire is 1.6. As far as screws go, the screw offering for any of the holes in these plates are going to be 2.7 diameter, 3.5 millimeter diameter, and 4.0. They'll come in a locking and a non-locking version. The locking has a variable angle capability of 30 degrees conically. And then all screws have a blunt self-tapping tip, have a hybrid pitch. So what I mean by that is not your typical coracle pitch, not your typical cancellous screw pitch. It's in between that, as you can kind of see here. So that provides optimal kind of purchase power of the screw in both bones, both types of bones, I should say, coracle and cancellous. And so you should see your consultants, surgeons really like and feel pretty good bite. Obviously, bone dependent, but the other thing that's certainly worth mentioning here is a tapered inner diameter as you get close to the head. And the rationale for that is from a bending standpoint, screws typically break over the first 2 or 3 threads. And so by tapering out the inner diameter, we have more material there to absorb the stress, absorb the force from that lever. So that's pretty differentiated from most of the systems out there. That's standard on all of our screws. It's more obvious on the 2.7, and as you get to the larger, the 4.0 screws, it's less obvious. All 3 sizes worth mentioning of the screws have the same size head, so that you can use them in any of the plate holes. The other thing to note, I think, is there is a nice radius on the non-locking screw heads. This is in comparison to, say, like the Paragon screws, which are kind of sharp. So when you do have to throw in a non-locking screw off axis, there should be less soft tissue irritation. We use the standard T10 drive socket for the drive mechanism on all of our screws. This is depicting here for the 4.0, 3.5, and 2.7 screw. The inner diameter respectively is 2.7, 2.3, and 1.8, and thus the drill diameter that we're using in conjunction with these is 2.7, 2.4, and 1.9 respectively. Everything will be color coded with an epoxy ring on the drill to match up the color anodize on the screw. As far as drill guide options go, we've got a number of different offerings here. As far as guides that literally thread in the plate, we've got 2 different options. One is the fixed angle locking towers shown on the bottom left, and above it are the conical locking towers for variable angle locking. So that allows 30-degree conical freedom. Again, the epoxy rings indicate which screw to use it in conjunction with, and the double epoxy indicates a lag for like a lag type drill bit. We've also got handheld drill guide options, and these are obviously a little bit dated as far as the CAD imagery goes here, but bear with me nonetheless. You know, there's 3 different sizes. It is worth noting that the 2.7 handheld is also the lag option for the 2.7 screw, right? So 2.7 drill bit would be your standard drill for the 4.0 screws, and it's obviously also your lag drill bit if you're utilizing a lag technique for the 2.7 screw. And then in conjunction with the 3 handhelds here, we've just got then the need for 1 double-ended lag drill handle. One other kind of unique feature to our system. So, you know, certainly there's other companies out there that have these locking towers that Lyndon had mentioned and kind of shown that, you know, you can thread into the plate and kind of use as a joystick to manipulate the plate placement, which all of our plates have kind of a bullet nose to them so that you can kind of slide them subcutaneously if needed. But the differentiator is, you know, and not everyone's going to use this, but some will like this as far as ease of use and quickness go. There's a depth gauge extension is what we call it. And so you can actually thread this onto the top of one of the handhelds so that when, you know, when the surgeon is drilling, there will be a laser line on the drill that you can that read off of this at any point. So, you know, if you want to throw this in off axis, you can, and just take a quick measurement right off of that. As far as wire options go, we've got 2mm wires that are mainly for reduction type need. We've got 1.6mm wires, which are to be used in through the plate, through the K-wire hole, through the slot, and then olive wires, which are shown here. Again, it's worth noting that the distal tip of the olive wire is 1.6 versus the back end of the olive is 2.0. We did this because typically, and we do have very, very small threads distal to the olive on the wire, but not big and beefy, so that if you know, if the wire driver is not put on reverse when you're taking it out, it's less likely to snap off. As far as bending instrumentation goes, 2 sets of bending irons, 2 sets of bending pliers, pretty straightforward. And then I just want to make mention of a few things to maybe keep your eye out for. You know, as this is not an image of one of our plates on the right, but I think it's worth noting that you know, when you have a tri-mount, there's going to be a lot of screws and potentially a number of plates being put in a small area and at varying degrees. So you're certainly going to have to be careful and cognizant of, you know, not running into other screws. You know, we've tried to design these plates, particularly the 2A and 2B, to work in unison, so that when they're placed in the appropriate location and utilizing the fixed angle capacity of the screws, they're not going to run into each other. But, you know, having said that, everybody's anatomy is slightly different, and you know, you're just going to need to stay on your toes a little bit. You know, it certainly could also happen when you're plating with the medial mal plate and you're running syndesmotic screws across with the fib. And also, you know, found it noteworthy to mention, you know, just to keep your eye out. I think that some of the views in which the radiographs are taken intra-op are or can be deceiving. So forgive these exact images of the plates. These are through some of our development labs, and so they're not necessarily indicative of the final version. But just for sake, when you're looking at an AP view here, it would seem like the Type 3 here, this Type 3 plate is in the joint. But when you look at it from a lateral, you can see that it's not really even close. So just, again, things to kind of keep your eye out for. This can also happen on the 2B plate here as depicted. And then also worth noting that, as far as screw and wire for that matter, angulation on some of these plates, we've designed the plates to be anatomic in nature. Sometimes that kind of flare, if you look at that posterior tib there, as you get distal or closer to the joint, kind of flares out, right? And so naturally, a screw hole would be heading towards the joint line. So again, just use caution as you get closer to that joint, and common sense in terms of maybe aiming that screw elsewhere, as is the case here on the medium mouth plate, super distally. This is same thing actually, just representative of wire, aiming the wire in an appropriate vector. Also worth noting that though our set does not have a syndesmotic tightrope device, we have tested it, and it does work in conjunction with like the Arthrex competitive tightrope, just FYI. As far as the Wagstaff fragment goes, we have utilized a size 2.0 to be able to fit through that wire hole, so to speak. It's up to the docs and consultants that you work with, what size of needle that they care to work with. But so that's a 3 metric. Other than that, we hope to, in short order, be able to arm you with a surgical technique, a sales brochure. We've also put together, with the help of Lyndon and Andy, a detailed surgical approach document that will be really helpful to have high level, interaction with your consultants with. And obviously some instructions for use. But we'll continue to build out, I should say, the sales and marketing, platform to arm you to sell appropriately. Any questions at this point? No? Super clear. Good. All right. So at this point, I guess probably makes sense to dig in. Andy, would you like to start first in terms of some competitive?
I think Lyndon's going to kick off, and I'll follow after him.
Sure, no problem. Lyndon, let me just transfer over presenting.
There we go. Can everyone see that? Okay. Yeah.
Yep.
Okay. So yes, this obviously direct follow on from what me and Andy have already been talking about. So I was given the Paragon and the Unite ones to talk through. So this is the Paragon set. Obviously, anyone who knows the Paragon set knows it's a mammoth set that comes in many big and heavy trays. The medium malleolus plate is the first one I'll tackle. So this is the one that they've got on their kit. They've got one here for the vertical fractures and another one which is the medial malleolus hook plate. Now, to give you a bit of background on this one, this is from a paper back in the BJJ a number of years ago, and this is kind of the classification really that most people use for medial malleolar fractures. It has its downfall, but if you just take it as said that this is what we have, the medial malleolar plate from the Paragon set only really treats the D type, so you don't really have any ability to treat in the ones below. Now, if you have a look, this is another paper that came out, I think this was last year, on the different types of fracture patterns. And as you can see, only 7% are treatable by use of the plate that we just saw. The transverse fractures, so these ones down here, could theoretically be treated by the hook plate, but most people treat it using screws. I would personally not use a hook plate myself. But then the comminuted fractures, their plate doesn't fix, but ours, due to this design, allows you down to the anterior clavicular fracture. This comes from our paper back in 2017, showing that with the postural malleolar fractures, there's many different types of fractures. Ones where you get posterior oblique, ones Y-type fractures, anterior oblique, anterior clavicular fractures. So none of these fracture patterns are you can treat using the plate that is currently on the Paragon set. This is it's a little bit different now because this is a wire hole rather than actually so this is one of the older development pictures. So this is a typical fracture pattern. So rotational injuries, got postural malleolar fracture, but then you can see due to the rotational injury, it's got a blowout, not medial, not transverse type fracture, or a vertical shear. You have a blowout anteromedial. So the whole point of this plate is that it actually rotates anteromedial before coming back on itself, allowing you to pick up these fracture patterns. Also, this tab down at the bottom, I'm not allowed to say this, but you can actually bend it, and that's the way that I would use it. Yes, Dustin, I know I'm not allowed to say it, but yes, the whole point of this one, I rallied for this tab because you can actually bend it underneath, and actually then it's a home run screw between these two. But otherwise, you don't use it and put a screw up the middle of it. So this plate really is a game changer. There's nothing on the market for medial malleolus like this. So the straight fibula plate that is on can be used on the side or the back like ours can. You have the anatomical fibula plate, which unlike ours doesn't have that bend, and you have this cluster distally. So in comparison to ours, similarities, they both have 3.5 and 2.7 screws. The advantages of ours over that one is that you have the holes to allow the Wagstaff and the ATFL ligaments repair. And also you have the K-wire holes, both proximal and distal, allowing you to put the positioning, which they don't have. So really, you have to hold the plate and then get your drill on for their ones. When this one, you can just put some wires in, get an X-ray, check your position, much easier to use, and then you put all your screws in. To comment on the Wagstaffs, this is a paper from our unit. We looked at both cadaveric and a load of CT scans with the Wagstaff, and the average Wagstaff position was here. And this is essentially the screw holes, the wire holes that you can put this thread through. It's specifically to encounter this Wagstaff fragment and the AITFL pull down. Also, that tilt that you have, so the way that it goes from lateral and it just curves slightly, allows you the best position for your syndesmotic screw. Your posterior fibula plate on the Paragon set has this little curve distally. To be honest with you, I've used the straight plate for years and have never had issues for it. But the one thing is that when the fibula at the back gets more proximal, it becomes triangular. So you become a point. And trying to balance your plate on it is an absolute nightmare. So with the use of this plate, what's very useful is the tower, number one, to position, and number two, you got tons of K-wire holes to balance it with, and then you just chuck your screws in. So it's theoretically has a much easier use when it comes to plate in the back of the fibula because of these, which you don't have in the Paragon. Paragon have got this tiny little trimalleolar plates. No idea what the use of that would be in truth. But they do have this posterolateral tibial plates. It's relatively well contoured. I've never used one myself. Quite similar to the ones that we have designed, apart from the fact that we have both a wider base to capture the larger fragments. The average width is about 2 centimeters, which this one is not. These are a lot smaller than the average fracture size. The K-wire holes also allow maintenance reduction. So what I usually do is position the fragment, put some K-wires in, put the plate on, put some K-wires, and again X-rays. And then obviously you've got the cheat hole, so the ones that you can provisionally put that one K-wire in, and then use that to push your fragment down. So the plate itself becomes a reduction tool. The type 2B plate, or the posteromedial plate on this set, I don't think they've ever seen a posteromedial fragment, because this doesn't happen. This is not a typical fracture. And also, where they put it is like the worst place you can put it. It goes straight down the middle of where your tibialis posterior tendon actually sits, bang down the middle of it. So not only does it bang down the middle of where your fracture is, also bang down the middle of where your tendon is. So this comes from a paper on posteromedial fractures back in the last year before. And this is the very, very typical fracture pattern. This is where the fracture lies, bang where the plate is. So essentially, if you're ever going to use this plate, you put this plate on and your screws go straight through the fracture. It just wouldn't work. It doesn't work. And actually, this is a copy of the Arthrex one that Andy will talk about, which again doesn't work. So another typical example, can you see this? This is a posteromedial fragment, a bit of blowout as well, but your fracture is exactly where your plate's going to be if you use that plate. I've talked about this earlier, and what you want for this is not for it to be over the top of it. You want it to be pushing from medial to lateral to get underneath the posterolateral to stop that splitting out. And that's what this does. So the plate, again, this is a bit of an old one because this is now a K-wire slot, is you push this on, and that's when you actually tighten it down. Now, one of the screws does incorporate into where the tib post is going to be, and we've beveled this to allow that to the tib post to reduce this irritation. Okay, I'll go through that one. So yes, so the other thing is that the size of the fragments, that your size is much larger for the type 3. So you can see these are very big fractures, and they don't have a type 3 plate on their system. You could theoretically use the straight plates that they use, but ours has the advantage of one that's designed specifically to encompass this large type 3 fracture. So the other merchandise, so they also have these straight fibula hook plates, be it, I can't ever imagine a time that I would use it for some of the AB ducted fractures. I think I do about 6 ankles a week and have done so for the last 5 years. I can imagine 2 that I might use this on. So it'd be a very rare inclusion. They also have these essentially peel-on plates, which we don't have in our set. So the next one is the Unite foot and ankle. So this is a rather basic ankle fracture plate system. So this is their caddy as compared to ours. So the fibula plates, so they have the lateral 2 straight plates and a posterior plate. This is really to encompass the third tubular type of plate fixation rather than lock and plate fixation. Similarities, they both have 3.5 and 2.7, but the advantages of ours, obviously, the Sinsmotti screws also have a locking option. For the really osteoporotic, there's something called transtibial fixation, where you use a solid plate on the outside and you fix with locking screws to the tibia just to prevent it failing. They actually don't have locking on these Sinsmotti screws, so you can't use it for that reason. Holes to allow Wagstaff ATFL ligamentous repair, as already talked about. K-wire holes, they don't have it, so you're positioning without being able to. It's quicker with the K-wires. So we've talked about that ones already. So posterior straight plates, both have again 3.5, 2.7. Curved distally on competitor, again, it doesn't really change what I do. And the advantages again is the tower and KY holes. The posture mal plate, they've got one plate available. It's rather basic. Ours again, the tower locks in. KY holes both proximal and distal. We have more options for the different fracture patterns. The evidence base and the design based on fracture patterns not generic, such as this one. Also, we have a large type 3 plate. The hook plate, medium mal, it's very thick. I'd be very concerned about using such as this thing with that thickness. We don't have a hook plate on our set. I know sort of Dustin's been talking about this. Our advantages really is that ours is thin and designed to encompass actual fracture patterns. The ones that they would be with hook plate, so I personally use screws. I know some people do use hook plate. This is pretty thick for a plate system. Okay. This is how they put it on. So you have to have these wires and then put this, the drills through. They also have a compression distraction device on their set. As Dustin alluded to earlier, so do we. And you can put the olive wires through this. Sorry, this one's through the slot and one have to get that so the plate actually moves with the distal front to get your length. And that's why sort of having the slot quite proximal, quite near the top is really important, because you put this distraction device on, put the KY above, and then you can distract it through the plate, which is pretty good. And that's my review of our competitors.
All right. Any questions for Lyndon in those comparisons?
Hi, Lyndon. Can you see me? Can you hear me?
If take me off presenter, Dustin. I can hear you though.
You can hear me. Okay, yeah. I'm happy with what you were saying about the classifications, and that both FAS are related quite well, and all the surgeons are quite familiar with it now. With our plates maybe being that little bit more complex and the algorithm that you brought out, would you say that some surgeons maybe aren't familiar with the exact approaches, maybe with our plates being that little bit more complex in terms of placement? Would you say it's something for us maybe to educate more in terms of making sure they do the right approach with our plates, as opposed to maybe just doing the easy option?
Yeah, so I think the type 2B plate would be the probably most underused plate for that reason. The type 2A plate is the one that's probably going to be mostly used. But you're very right. This comes with a new education on approaches and uses.
Yeah, yeah. So there.
Sorry, Karen. I think one of the this is one of the things when we first spoke to Author Solutions about it that we wanted to go through. So you supply the whole education portfolio around it, because I think most people, you'll get some people who will think, just as you said, is that this is the difficult option and the easier option would just be to use one of these generic plates just for a posterolateral incision. But that clock face article where we show where Lyndon was showing how much of the back of the tibia you can see from each incision. So basically we did the incision, then put K-wires in and measured how much you could see. The trying to use those generic plates and doing it through one type of incision is actually the difficult option, because you can't get to the bit that you want to, and the plates don't fit. So although there is more modularity in ours, it actually makes your life easier. Yeah. And in approaching the fracture.
Yeah, okay. So we just need to be fully aware of these approaches, and just to help, let's say maybe not the foot and ankle surgeons, maybe the knee surgeons that we might pop into or something, that we just want to make sure that they're actually using the right approach for the right plates, and that's probably quite key in this, you'd say.
Yeah, yeah, absolutely.
Yeah. Okay. All right. Thank you.
Any other questions at this point? Okay. Andy, you want to giddy up on your segment?
Cool. So going head to head with Acumed and Arthrex. Right, so Acumed, they've got 2 sales brochures and 1 surgical technique. Personally, I don't particularly like the brochures. I think they're quite difficult to follow, and very basic in the information that they give out. The more product overview, they don't talk about approaches or only in very, very minimal detail. So they're straight lateral fibular plates. So this is 4 to 13 hole with a distal cluster, and the syndesmotic hole, they've got 2 of them here, which are angled 30 degrees anterior. They accept 3.5 millimeter screws proximally, and in the cluster it's 2.7 mils. They do have multiple K-wire holes, and they do have towers that go that screw into. So I think the main advantages for us, I think overall it's a pretty decent plate, but it doesn't have the fibular twist that Lyndon alluded to. And it does have a K-wire hole here, but it's not quite correctly positioned, I don't think, or it's difficult to see from the information they put out for fixing your Wagstaff fragments. The posterolateral plate, as Lyndon was saying before, is it's not really clear from their brochure about whether this just sits posteriorly or posterolaterally. I don't particularly understand, but it's got this curve on it, which, as Lyndon said, I've just never found necessary. It's not to say that it doesn't fit. I'm sure it must do, but it's not a deficiency, I think, in just having a straight plate. And again, so otherwise there's little difference. It's got the multiple K-wire holes and such like. So they're posterior malleolus plates. So these are based on 2 papers from Anish together with Jeff, who I know well. So the main paper was the one from FAI in 2014, which was 5 years after their initial one, just looking at, it's interesting, their initial paper in 2009 just looked, together with Norman Espinosa, just looked at 9 posterior malleolar fractures where they only used the posterolateral incision. So this paper that they went through looked at 270 fractures, 50% of them posterior malleolar fractures, but they only had scans on 15 of the posterior malleolar fractures. Now, I don't know whether they based that for how they designed the plates, but that's the evidence that they tried to base it on. And really, the paper was looking, it didn't talk about any true classification system. It was just looking at correlation between the Laurent-Hansen medial and lateral malleolar classification system and whether there was a posterior malleolar fracture present. So their 2A plate, again, is reasonably, I think, designed. You can see you can use the olive wires. It's got towers which fixes in. It sits down really very low. You're going to have to divide quite a lot of soft tissue to get that down onto there. But I think overall it's not too unreasonable. I think ours is better because it's got a wider base. This is really quite narrow, it appears, for the size of fragment that you typically get. As Lyndon said, our average width was 23 millimeters. And ours has that oblique hole to allow the initial fixation. So I think Lyndon called it a cheat hole. so that you can aid in reduction, so that it is, as you put that screw in, it will make the plate go in a distal direction. Because if you're going to malunite these, obviously you can put them over to lateral, but it's usually that they're still just a little bit raised. The type 2B plate, I think Lyndon put it very eloquently on the deficiencies of the Arthrex one, which is the same as this. So this basically sits under the posterior tibial tendon for its entire length. They say that they've smoothed the bevel at both ends of the plate so that it won't rub against it, but the whole of your tendon is going to be on there. And really, where down on its distal portion, the tibialis posterior is really snug in against what is almost like a cartilaginous surface there. So that is going to have to rub. Again, they've got 2.7 mil screws distally and 3.5 or 4 proximally. So just going back to what Lyndon said, is our plate obviously comes round the side here and prevents that spit out. Their plate is just here, which is just right on your fracture line. And so I think you're not going to be able to use the screws, or it's anatomically made for that area. So otherwise you're going to be having to try and put it over here when the plate won't fit. So I think ours is significantly better than that. So the type 3 plates is almost like a bit of a copy of the old Hand Innovations F3 plates, which DePuy bought. On their small fragment set, they have 4 of these plates, but it's really that T plate, which is how which they recommend, and you can cut this to size. It is non-contoured. Now, it's only quite a thin plate. Now, they interestingly don't give any of the dimensions of the plate in their brochure, so I can't say how thick it is, but it looks like it's going to be pretty thin and flimsy, so maybe the screws will take it down. But they've only got 2.7 millimeter screws, and these are pretty big chunks. So I think you are going to have to contour it, which means putting it on and putting it against the bone and then bending it, putting it back on. And there are no K-wire holes to hold that when you are. So I think that's going to be relatively tricky to do with the incorrect screw sizes. I think there's a large amount of fiddle factor with that plate, which I don't think is overly well designed. So the medial anti-glide plate, which has got, again, 3.5 or 4 mil proximally, and it's only comes in a 4 hole. Again, the dimensions aren't put on there, but on one of the rotated images, it looks like it's a pretty thick plate. And as Lynn said, is that here you can see a diagram that was put on. It's only going to be for a type D fracture, and it's a thick plate. In a lot of people, there is no subcutaneous tissue. There's very little subcutaneous tissue there. I think the range of metalwork, the rate of metalwork removal will be extremely high, and I would be a little worried about having an incision over the top of one of those plates and someone who is a type B, a poor host, it might isn't you diabetics or neuropathics or whatever. Medial hook plates, I must admit, they're not my favourite things on earth. They do a 2 or a 3 hole. They're really very thin. You can come in with a hook or with a locking peg, which goes into it. So I think from how it looks that it's made is that you're going to have to put this pretty central in the medial malleolus, which is fine if we go back, if it was just from that classification system, a type A fracture where it's just simple transverse, I can imagine that can help. But if you've got one of these anterior collicular or a Y fracture or whatever, is that is not going to pick those up in a reliable fashion. Now, I'm sure they say you could pass a screw in addition to it and things, but I don't think there are many fractures that you're going to be able to use that for. And certainly the paper that Lyndon quoted, that showed that 12 out of 107 of the medial malleolar fractures, or about 10%, were comminuted. So you're not going to be able to use these for comminuted fractures. You're just going to really be using those for the type A, which you think are too small to get screws in. So this is the Arthrex caddy. They haven't quite gone as big as Paragon have with the amount of plates that you can fit in one tray, but they've still got quite a few in there. So they have their complex fibular fracture, which I know is a personal favourite of Lyndon's when we used it. That is intense sarcasm, in case you were wondering. It's proximal 3.5, distal 2.7, 4 to 12 holes. Now, really, the design rationale behind this is all about using a tightrope. So you can put the tightrope through any of these holes, or they put these waves into it, so you can put the tightrope to the side of the plate, which suggests that the angulation that you can get for putting your tightrope here with it sitting at flush is that you can't angle it at all, which is what we found. You've just got to go pretty much straight across, otherwise the button doesn't sit in it. It is a really quite thick plate, and anatomically we didn't find that it fit very well onto the fibula. Quite a lot of the time you're having to put this, the couple of times I've used it, is you have to put it quite proximal. You can't go right down to the tip of the fibula, and there's no wagstaff fixation. The long third tubular plate is just fairly standard. There's nothing with that. Now they've, sorry, let's move across. Now they've come out with the new titanium ankle fracture system. Which has got 4 millimeters approximately 3 millimeters distally, fits a tightrope, and it has eyelets for the AITFL internal brace, which I don't know anyone who uses. I mean, you could use a tightrope for the AITFL if you wanted. An internal brace I see as being complete overkill for the use of that, but anyway. So there are two of these titanium plates, which is curious. One of them is anatomic, and the other one is just a posterolateral plate. So I presume that means it's non-anatomic and doesn't fit that well. It looks really quite, it looks very thick. And if you see here, it starts off on the back and then curves onto the lateral aspect. So I'm not quite sure how you repair your perineal retinaculum up here. You'd obviously still have perineal retinaculum around here, but I would be worried about subluxation of the perineal tendons against this, or peroneus brevis rubbing against the plate. Again, they've got a medial hook plate, which is similar to the Acumed plate. Again, they don't have the dimensions of it. It looks a bit wider than the Acumed plate, but just the same reasons that I said before, is you're going to have to place this centrally, so that will go well for your type A fractures. But if there's comminution, or if it's one of the oblique fractures, is I don't think you're going to be able to reliably pick that up. They have a lateral hook plate, which again, I've never felt the need to use. I'm presuming they're saying that's for very, very distal fractures. It's a thick plate, as you can see, but that is going to have to impinge against your perineal tendons. So I think our plate, even if it was just a tiny small avulsion, even just having a plate with one screw going into it and keeping the non-weight bearing plaster, would be better than putting this in, because I think you're going to end up with a lot of perineal problems afterwards. They have, I'm led to believe that they may be coming out with some posterior malleolar plates, but I couldn't extract any more information than that. They just have one on the system, which is 3 to 9 holes, which I presume you could use for a type 3, but obviously you couldn't use that for any of the other posterior malleolar fractures. That's me up on that.
Great, thanks, Andy. Does anybody have any questions specifically to any of that content that Andy just presented, or for that matter, anything previously?
Quick question, Dustin. Do we know who is most prolific in the UK in terms of supplying this product?
I don't have the answer to that, Dara. Elliot or Sheena or somebody is probably better positioned to answer that, honestly, than I am.
So I don't.
What do you think, guys?
So I don't have any figures on them. For a lot of how trauma hardware is provided is through the tender process. So I think a lot of the plates will be Smith & Nephew or Stryker or Synthes. Now, for most of those trauma tenders, they tend to go for 80% of your trauma cases need to use their plating system, and 20% can't, or if it's something which isn't involved, isn't supplied by their portfolio. To my mind, for this is that, say, Stryker don't have, which is what our trauma tender is at the moment, although it's going back out, they don't have a posterior malleolar plates. So for that reason, you would be able to get in and sidestep the trauma tender. For the others, I think that they're relatively small. I understand that I think Paragon is pretty popular in the States, and Arthrex probably behind that, as well as the other big companies. But so we just focused, Dustin spoke to us about it and told us to focus on these ones, because these are the ones who have come up with specific ankle fracture things and are looking towards the posterior malleolar plates. And it probably sounds like we were being overly harsh, which isn't normally the way that we talk about things, but I thought it was important to be relatively blunt about them. But there's the odd good plate, but there's some huge deficiencies in what is out there in compared to what Ortho Solutions is providing.
That's helpful. Thanks, Andy. It's interesting that the big three or the big four don't really feature in terms of this offering, which I think is good for us, as you say.
So, Dara, I would echo absolutely and agree with absolutely what Andy has said there. Many of the accounts that I've been looking at and been into very much use those big trauma contracts such as Stryker, and they don't have a solution for this patient cohort or this fracture management. There are a couple of accounts that Arthrex have won the trauma aspect to it, or they've done some sort of bulk contract with that particular account, perhaps not with just specifically trauma, but their trauma plates have been an add-on. But the big accounts are like what Andy has suggested, is Stryker and Synthes, and there are other accounts with Acumed as well. Acumed are making very good kind of strides up here in the northeast anyway.
Any other questions?
I'll ask just a really silly one, probably, about the screws. Having not worked with the trauma stuff before, just the blunt screw head, is that pretty normal, common with the obviously with the arteries and the muscles that you'd be going through with malleolus? The blunt screw head that our design is, as opposed to, let's say, our Altos that have got quite a pointed end.
Yeah,
so they're usually in between. It's usually in between, to be honest. It does appear to be a little bit blunter than the normal, but the ones going from front to back of tibia, if you're going through the anterior cortex, you do have your deep perineal nerve and your dorsalis pedis artery. And I have had a few tickling of screws to these structures, the pointer screws. So it is a theoretical advantage to the kind of softer shoes at the front when you're going through.
Okay, cool.
And Karen, I do believe that we actually tapered the ID down on that distal tip towards the blunt tip as well, just so it doesn't feel like it's a big blunt tip kind of sticking out. But anyhow, I think it's fairly analogous to, as far as like the blunt nature, some of the competitors, like the Paragons out there. But again, all this stuff, we certainly want to collect data and feedback, as we progress through the launch. So please do feel free to share the feedback with us.
Okay, yeah, we'll use it as a selling point then more than anything. If it's not common with all the other competitors, then at least it's something that we're more unique with, I suppose.
Mm-hmm. Yeah, right. I mean, it is a different design than the Altos. We've fundamentally changed the design from the Altos screw with respect to the pitch and the OD to ID ratio and the ID tapering out under the neck. So it's it'll probably have a very different feel, than the Altos screws.
Sure.
I would probably phrase it as rounded end rather than blunt.
Blunt. Okay.
Any other questions at this point? Okay, so I guess in closing, first again, thanks, a big thanks to Andy and Lyndon for your time and the effort that you put in presenting. From the Ortho Solutions side, we'll try to push through in the next week or two a lot of the literature and get that signed off and into your hands so that you can study up and become sharp on the selling side of things. Elliot, is there anything that you care to add on at this point?
No, I'd just like to reiterate what you've just said. Thank you very much, Andy and Lyndon. Really appreciate your time and efforts with that. I think everybody's going to be super excited now to get the few kits that we've got coming out there, and as soon as we can, we'll get them to you.
I mean, I would just say again, thanks for putting this on. It's always great to do. We look forward to seeing you guys hopefully in AFAS and at BOFAS. I'm more than happy for Dustin and Elliot to give my email address out if there's any questions that you want to ask, or if there's any things that you come across when you're starting to speak to the surgeons, who tend to be pretty good at responding to them. So please feel free.
Okay, thanks for that. Will do. All right. Well, on that note, again, appreciate the attendance. I know that you guys will have questions as we start selling it, and glad that we can do this, albeit in person. Wish it was in person, but nonetheless, it's better than nothing. So that said, have a great weekend, and I'm sure that we'll be in touch.
Thanks all.
Thanks, guys.
Hey, guys.
Thanks, guys.
Okay, thank
Cheers. Bye. Bye.
Thank you.
I think you can stop recording if you hit it.
I thought I did.
You gotta hit that, then hit stop.